Good afternoon. It's a pleasure to be here today. I'm actually Zambian, currently based in the US, and I do both basic science and clinical science. And my area of research is the hippocampus. And essentially, we try to figure out the neuronal interaction, the neural networks that explain much of our behavior, and how, when they go wrong, can explain things like epilepsy, memory loss, and those kind of things. My particular focus area is deals with learning and memory, but the clinical part of it looks at the sleep disorders, and even those have a relevance to what we're talking about here. Now, I've sat in today and I've listened to so many wonderful talks given, and so this slide essentially is just summarizing most of the things that you've already heard. When it comes to epilepsy, there are all kinds of causes that lead to seizures. And in the bench, we are trying to figure out what the exact mechanisms are, because if we can understand that, they will inform the kind of drugs that we need to treat these conditions. But whatever the cause, essentially what happens is that you disrupt this balance that you have between excitation on one hand and inhibition. And whenever that balance is off, whatever the cause, you get hyperexcitability, and that leads to the seizures or epilepsy. So this little cartoon here, am I going the wrong way? This little cartoon pretty much summarizes. So we are still in the basic lab, we are still trying to figure out exactly what it is that is going wrong. I think we have answers in a lot of situations. The clinical side has not yet caught up on that. But whatever the cause, you have this excessive depolarization, and then all these discharges, and you have your seizures. And most of the drugs that are out there on the market tend to try and minimize or diminish or stop these seizures once they're in place. And so the phenobarbs, the diazepams, and all of those things, for most of them, that is the target area. You get your discharge and your seizure. Now, I was asked to focus mostly on status epilepticus in children. And there are all kinds of definitions that are used to determine whether someone is having status epilepticus or not. These are the seizures that no longer respond to the first line of drugs in trying to control them. And the typical definition that is given is that if you see a seizure going on beyond 30 minutes, then you have developed the status epilepticus. But it is now being recognized that you don't even have to wait for the 30 minutes. It can be as early as 5 minutes, and you have the condition. So for practical purposes in a child, when you see a child presenting with tonic-clonic seizures lasting more than 5 minutes, it is time to act. The other thing about this condition is that even though we tend to focus a lot on the convulsive seizures, in actuality, there are also non-convulsive seizures. And these are actually much more frequent in children than you have in adults. So this cartoon here is not only taking status epilepticus, which is developing, even though we tend to focus on this type, these are the ones that are just as equally important to look at and treat. And we know that because studies are coming out. Now, I know this is a busy slide. I just want you to focus on one thing, and that is if you do not treat the status epilepticus, the consequences of that are very severe. And it doesn't matter whether it is convulsive or non-convulsive, the consequences are very severe. So if you look at this diagram, this is what happens when you don't treat all these seizures. There is brain damage of all types. And as you can see from this diagram, if you can just focus on that, if you don't treat the convulsive seizures, they do lead to a lot of brain damage. But even the non-convulsive seizures are also associated with severe brain damage. And like I said, these are the ones that are most common in children. Even though we hardly ever focus on that, we tend to focus on these ones. And for seizures, you normally have seizures and then you can control them either through the natural homeostatic mechanisms or through drug treatment. You get into status epilepticus when you start having those seizures repeating themselves and they tend to merge. Now, there are all kinds of drugs that are used, And like I said, the drugs that we have on the market tend to focus on diminishing the storm once it has started. And so most of the drugs that are available today tend to target that. And the work that I do and others like me who do this kind of work, we are trying to go before this step and try to discover drugs that actually stop the initiation of the seizure itself. The ones that are highlighted here are the ones that almost every country should have. And as we've heard from most of the presentations here, that is not the case. There are a lot of newer drugs, but all of them have the common theme, and that is to minimize the discharges once they start. Now, there are all kinds of drugs. These are the common ones. I'm a pharmacologist by training, and oftentimes we learn a lot about the disease process by understanding how the drug is working to either minimize it or treat it. And if you look at the spectrum of activity for these drugs, this is the spectrum that you get. Depending on the type of seizure that you're having up here, these are the different types of seizures. Carbamazepam, for instance, is very good for this idiopathic type and these kind of seizures. If you go to the famous one that we tend to use around here, phenobarb, it has a much broader spectrum, and that's one of the reasons why it is popular in the clinic. The other drug that has got a broader spectrum is valproate, and these two are really the mainstay for most of the epilepsies across the world. Phenytoin also comes in, but these other ones are not as widespread. So this is just to give you a cartoon picture of the spectrum of activity when to use what drug. Now, the trouble with treating children is that most of these drugs came into the clinic following clinical trials, the phase 3 and the phase 4. And until more recently, almost all of these drugs were tested and tried out in adult populations, never in children, let alone pregnant women. And so when it comes to choosing drugs to treat these conditions, when we go back to the children, we do not have any evidence-based reason why we should be using whatever drugs we're using. We are just going empirically. And over time, that has formed a way of treating these conditions. There are very few drugs that have actually been tested in children to see how effective they are. And so they do work. Now, in terms of if you're presented with a child or a pediatric condition of epilepsy in general, and this becomes status epilepticus, in this cartoon, even though it is very, very busy, these are the sort of the standard procedures that you must follow if you're going to save that child or help that child. There is no agreement among different centers that are treating these conditions. Oftentimes, it is all center-based, but all of them have some common themes, and these are what I've tried to capture in this slide. And in Africa in particular, you also have to consider the conditions that you have. You may not have access to an IV to be able to do all of this. And so I've included on the right what you may have to do if you do not have IV access. Now, you may also have IV access, but you cannot find the vein. And so I've also included the alternative that you might use. There are three basic things that you want to make sure they are always in good condition. You must make sure that your patient, the young child who is brought to you, the airway is clear for breathing purposes, for obvious reasons. The breathing must be normal, so you must do whatever you can to take care of those basic things, breathing. But above all, circulation. You also have to monitor that. Now, it does not matter what that child has had before they are brought to you. You just assume whatever they had out there did not work. If it did, they would not have brought the child to the hospital. So you start following these steps. The first drug of choice is a benzodiazepine. In the African setting, I think diazepam is much more available than lorazepam. But whatever the case, lorazepam is representative of that. And you start off with about 0.1 milligram per kilogram IV. And you give that over a period of 1 minute as a continuous infusion. After about 10 minutes, if you do not see any progression, any relief in the seizures, you repeat that dose, lorazepam or benzodiazepam. If after the next 10 minutes there is no response to that drug, you then switch on and try phenytoin, and one of the suggested doses is what I'm showing over here, 18 milligrams per kilogram for IV, and then you monitor the child. And if after 20 minutes, even that is not working, you may have to, now of course, if the child has already received phenobarb, then you don't give more phenytoin. You go ahead and, I mean, if the child is already receiving phenytoin, you don't give that. You go and start with phenobarb. And now, at this time point, when you've given benzodiazepines twice and there's been no relief, and you've given phenytoin, when you're giving phenytoin, you also need to add these additional drugs that I've listed here, paraldehyde with a dose of 0.4 milligram per kilogram, and you can give this rectally. You don't have, this is not an injectable, you give it rectally. And you must also give the same volume of olive oil, and I'll talk about why you do that while you're doing all of that. Now, if none of those measures have worked, it is an emergency. You want to bring that child into complete anesthetic condition, and that's what you have to do. And in those places that have propofol, for instance, that is what they're preferring. Thiopentol will be just as good. So if you try all those first 4 steps that I've listed up there, and the child is still in seizures, induce complete anesthesia. Just knock them out, and then look for other options. That is using the IV route. If you use the non-IV route, like I said, rectally, you can do all of that, and then you get to the bottom part, and you induce seizure. You have to give things like thiamine and glucose and pyridoxine for obvious reasons. Working muscle consumes all that sugar in the blood so much that if you do not replace it, you're going to run the risk of inducing hypoglycemia in the child, which will be just as bad as the seizure itself. And so all these additional steps must be kept in mind in order to preserve the life of a child. And later on, I'll be available, can talk about that some more. Now, there's also another way. In those situations where you cannot get the IV in, or you cannot find a blood line for injection of the IV, you can also use intraosseous route. This is when you do infusions. You take a needle, push it right through, get into the bone marrow, and then start your infusion there. It works just fine in children. And this is a cartoon that shows one of those steps. It can be in one of the big bones. The one that is most preferred is the one in the leg. And as you can see up here, you have the needle, you can inject through. There are certain basic procedures you follow to make sure that you're in the marrow, and then you start your infusion, and it works just as fine. In fact, it is a lifesaver. So those are some of the things you want to keep in mind. Now, sometimes the treatment that you're giving your child is accompanied by the worsening of seizures, and this is actually the focus of my research because of the worsening of the seizures. And there are some disagreements between what we do and what others are doing in the clinic, and I'll try to explain what those differences are. Now, again, when you give these drugs, essentially you're targeting this area here. You have your action potential, or the discharge that is allowing movement, communication between neurons. If you can interfere with this process, the way you should interfere it is in such a way that you should be able to have the action potential, but it should not repeat itself thereafter. And most of the drugs that we have actually do just that. Another way to prevent a seizure is to make sure that it is very hard to generate the action potential itself. And you can do that by lowering this resting value downwards. And when you do that, it will require a lot more stimulus to reach some threshold point before you can have the discharge. And some of those drugs do that. Or you can try to move this all the way down to a point where, it takes longer to get to the threshold point in order to get the action potential. Those are some of the things that you're trying to do. Because, like I said, what is going on is an imbalance between these two processes, and whenever you have that, you have seizures taking place. And the drugs that we have, and here I've just listed some of the mechanisms of action, but I want to highlight 2 of them. It increases GABA inhibition. It increases GABA diazepams and phenobarb. It do just that. They make it more difficult to fire action potentials in the cell. That might be a good thing in an adult population, but in children, that can be disaster. And that's one of the reasons why I would not recommend that if you see the signs of trouble. And why is that? Well, in the current theory out there, and there's a lot of clinical evidence to back it up, is that when you start giving this first line of drugs of choices, which tend to enhance chloride conduction, chloride is getting into the cells through special channels called GABA A receptor channels. And if you continuously activate this because of the continuous discharge, the idea is that you start losing some of these channels so that you have fewer of them up there. And because you now have fewer of them, the drug stops working. And that makes perfect sense. I tend to take a different view. That yes, that might be the case in some of the cases that we have, but there is another thing that the clinic is telling us is also going on, especially in children. And this thing is illustrated here. Oftentimes, when you have one action potential, you don't have another action potential because there's a huge hyperpolarization that has taken place. This is what the chloride and the GABA A receptors are actually producing. Now, if you have multiple of these because of the seizure, actually this sums up and becomes much bigger. And if you then all of a sudden manage to stop that because this inhibitory drive is very large, when you let go, you actually cause a rebound response and initiate the whole process again, which is what is shown in this diagram. There was some individual spiking, which is normal. Then all of a sudden you have a seizure activity over here. There's a build-up of inhibitory drive. And when you manage to shut off the target node from firing, that stopping of the brake actually causes a rebound. And because of that rebound, you start having more seizures. And so for a drug like benzodiazepine and phenobarb, you actually don't want to put it in a situation like that, because what benzodiazepines and phenobarb are doing is actually to create more of this. And so when you have this going on because of the seizure, and then you have a drug that makes that even worse, the rebound is going to be much more worse. And that will induce seizures in children. And why is that so important in children? And I'm almost done. I have about 2 or 3 more slides. Why is that much more important in children? Well, in children, these GABAergic receptors do not start off as those that are going to inhibit responses. In children, young children, they're actually depolarizing. They're actually excitatory. And then you go through a phase where you have a reversal and they become inhibitory. So young children, especially in the first 3, 4, 5 years of life, you're actually going to have immature GABA receptors that do not inhibit, that if anything actually excite. And so you want to avoid anything that's going to add on to that. And this is why it is probably not wise to be very careful when you use benzodiazepine and phenobarbital. I have one more slide. Now, I've heard of, and the clinical evidence is very strong for that, because as you've heard earlier on, some of these seizures become worse when you actually go to sleep. And sleep is the research, which is one of the research that I do. And what happens in sleep, that there are certain stages in sleep called REM sleep, when the muscles become paralyzed. If you record in those neurons that control those muscles, they are completely hyperpolarized, completely hyperpolarized. And so you find that once they begin to wake up, they trigger a seizure because you're getting rid of this type of polarization, and then all of a sudden you're having that rebound effect, and then you have your seizure. And there's so many other evidence that I can pull from the clinic that address that fact, that we have to be very careful, especially in the first year, second, and third year, because these seizures, the inhibitory drive, can actually become a generator of more seizures. And if you add more drugs to that, you just make it worse. One other point before I end, and then I'll take your question, relates to, that's the only one. One other thing that relates to the fact that when babies are born, first of all, the brain takes about 20 years before it can be completely mature to do all the things that it does. When babies are born, there is a reason why there is no, it is still going through the developmental stage where you're having the hooking up of the central nervous system and the skeletal muscle system. And that's why their movements are all over the place. And that's one of the reasons why you don't see most seizures, because there's still that disconnect that is still developing until you balance those two things together. So in the first 2 or 3 years, it's not likely that you're going to be seeing mostly convulsive seizures, except the usual one here and there as the connection is complete. You're most likely going to see those subtle signs that say there's a seizure going on. And under those circumstances, you have to be very careful with the treatment. This is my last concluding slide. And it essentially says we need to start communicating and talking and everything else, because there is no clear treatment for pediatric that is agreeable by everyone. And yet in places like Africa, you see a lot more cases than elsewhere. But much of that information, you yourself keep it, and you don't have a way of letting it out. And perhaps that is one other area that we should try to improve on so that we can learn from those experiences. Sorry for going over the time, and thank you.
Thank you.